Welcome everyone to today's Reproductive webinar by the Global Antibiotic Research and Development Partnership, GARDP. My name is Victor Kwasi, and I'll be hosting today's session on implementation research for the appropriate use of and access to antimicrobials. Revive is GARDP's education and outreach program. It aims to connect and support the antimicrobial R&D community by facilitating learning, sharing knowledge, and connecting people. These webinars are part of our educational activities. All of our webinars are recorded and freely available to view after the live session on our website, revive.gardp.org/webinars. You can also read our series of articles known as Antimicrobial Viewpoints, where experts discuss various topics within the field. We also have a resources section that includes the Antimicrobial Encyclopedia. This has definitions on various important terms, including those that will be discussed today. And some of these include new videos where experts give a further explanation of these terms. As always, today's presentation will be followed by a Q&A session. You can submit your questions at any time during the webinar by clicking on the questions button as shown on this slide. We will address the questions after the presentations and do our best to respond to as many as possible. If your question is for a specific speaker, please do indicate their name at the beginning of your question. Today's speakers are Joy Lawn, Malabika, Sarker, and Christine Halleux. Our moderator today is Fernando Pascual Martinez. Fernando is Access Development Lead at GARDP and is in charge of defining research projects needed to generate supportive evidence for introducing products in low and middle income countries. He is a pharmacist who also holds a Master in Public Health in Developing Countries from the London School of Hygiene and Tropical Medicine in the UK, and is specialized in access to medicines and quality assurance of pharmaceuticals in developing countries. Welcome, Fernando. I now hand over to you to moderate today's webinar.
Thank you very much, Victor, for this introduction. And now, without further ado, we can move to today's webinar. We have three distinguished speakers who will guide us through the topic of implementation research and how to use it to support appropriate use of antibiotics, and also, very importantly, how to improve access. Our first speaker is Joy Lawn, who is a Ugandan-born neonatal doctor and perinatal epidemiologist, currently professor of maternal, reproductive, and child epidemiology at the LSHTM in London. She leads a research team working on multi-country studies covering newborn health, stillbirths, and child development, including a large implementation research with Nest 360 Alliance. She currently co-chairs the Lancet Commission on Evidence-Based Implementation, and she has published over 370 peer-reviewed papers, including several Lancet series and UN reports. Her master's degree was from Emory in Atlanta and her doctorate degree from the Institute of Child Health in London. So now you have about 15 minutes to talk us about implementation research and how can we close funding gaps and democratize methods for local use. So Joy, the floor is yours. Thank you very much.
Thank you so much, Fernando. Thank you, Victor. Happy Tuesday, everybody, in case you don't know what day it is. And it's such a privilege to be here. And hopefully I will be able to manage this without over-clicking too fast. Yeah, I'm a massive fan of GARDP, and it's really exciting to see your encyclopedia, see the community, and see much of the work that you're doing. So really honoured to be here today with such a fantastic lineup. And I want to start by reflecting on the research pipeline. So in GARDP, you're trying to bring together, as Victor said, the R&D world. And we don't want to compete across the different parts of the R&D world. We need that kind of descriptive epi of the problem for antimicrobial resistance. We need more discovery, especially new antibiotics. We need development, for example, of diagnostics. But to reflect whether it's what we do for antimicrobial use or for any topic, particularly in high burden settings, but also in high income country settings, that the most rapid impact actually comes from the far right hand side of the pipeline. So the delivery or implementation research, implementation science, whatever language or acronym you want to use. So this is the highest impact. And at each point of the pipeline, we will have better results with unlike minds, with an interdisciplinary approach. But that's particularly true with implementation science. And yet, despite this being likely to be the highest impact, it's the lowest funding in almost any analysis that is done. So there's the classic WHO report on the 90-10 gap, which is now 20 years ago. So if we want to look at today, we want to use AI to work out what is funded and who funds what and where and how. So I don't know how many of you have heard of the Dimensions AI database, but this is an amazing database with more than 7 million grants. You can look at topics, amounts, who funds what and why. And it's actually not been used very much to assess systematically research funding to topic. So it may be actually something that GARDP would consider doing. And this particular paper that I just want to show one slide on, and I'm not going to go through it in detail, so here's the QR code to access the paper. But we looked specifically at research funding for stillbirths and neonatal deaths, with a focus on low and middle income countries and over the last 10 years. And the top message here is a massive surprise to us. First of all, that there's about 577 million spent each year on this, and there seems to be a bullet that has dropped off the bottom there, but only 7% of that goes to low and middle income countries, which have 98% of the burden. So big inequality. So we do these analysis and research not just to measure the problem, but to look at it in detail and to see how does the data link for changing and for accountability. So if we look within this database to say what topics are funded, neonatal infections, including actually quite a lot of research on antimicrobials and stewardship and resistance, is the top topic. The second biggest topic, which is the largest cause of child deaths up to the age of 5, is neonatal deaths. So both is neonatal deaths due to preterm, so preterm complications. And really shockingly, actually, stillbirths, so deaths in the last 3 months of pregnancy, so 1.9 million a year, are hardly mentioned. And this applies also in the US, as well as in low and middle income countries. So the US has about 14,000 stillbirths a year, and yet research within high income countries is still missing stillbirths. And I'd really encourage you in GARDP to include stillbirths in your outcome. So for example, in the Group B strep value case for vaccines that we did with WHO a couple of years ago, adding the stillbirths doubles the value proposition because it's a large number of deaths. But our focus on this webinar is on types of research along the pipeline. So if you look at this paper in more detail, like many other evaluations, most of research funding is spent on the upstream discovery science, so around half. And in this case, about 3% is spent on implementation research. So major gap. And so, you know, I'd encourage you to read this more. I'd encourage you to think, can you do a similar analysis for antimicrobial resistance? But what we want to do with this data then is to say, how do we use it for change, for equity? How can we better match research funding by place, by burden, more on implementation research, and especially more on low and middle income country leadership. So just today on the Newborn Toolkit, we launched this Newborn Toolkit research funding map. We got some money actually from a Dragon's Den competition to develop the map. And the map takes the data from that paper that I talked about, and you can go by country and see what research is being funded, including on neonatal infections and including on antimicrobial research. So, for example, if you zoom in on South Africa here, so the biggest number in low and middle income countries is actually in Brazil. And I'd like to flag that Brazil are doing a great job because the Brazil government is funding the research within Brazil. So that's really excellent. In South Africa, 52 grants. And I don't know if any of the fantastic South African neonatal research, neonatal infection research people like Prof. Dromarski and others are on this call, but a sizable proportion on neonatal infections, but actually depressingly few on implementation research. So I'd encourage you to use this map and see what you can find, see who you can link with, and see if we can use it to change things. But I now want to zoom in on actual implementation research. And first of all, what is it? So if you go to Google and you ask for the highest cited paper, or go to AI, ask for the highest cited paper on implementation research definition, it's this paper by the wonderful Professor David Phillips, David Peters. And in this paper, which has been cited a sizable number of times, and this PowerPoint seems to have a life of its own, underlines the fact that in implementation research or science, the question is king. It's a little bit gendered, so maybe we can say queen or empress or whatever, but the question is the critical part of implementation research. So I'll ask three questions. What is implementation research? How can we define it? How can each of us do better, whether we've been doing it for 20 years or we're starting out now? How can we do better? How can we get going? How can we do more? How can we help others? And then just one slide on the Lancet Commission on Evidence-Based Implementation. So moving forward onto the definitions, if you look at this, there are hundreds of definitions. It's actually slightly overwhelming. So at the top, you can see the definition from this most highly cited paper from David Peters. You can see an AI definition. You can see one example of a formula. There's actually lots of different formulas that people put out. You can see that UNICEF have quite a practical one and a very useful one also on embedded implementation research in a paper led by Deborah Jackson when she was there. So it's actually slightly scary if you're starting out. So if we move to the next slide, if we boil it down, what is implementation? So the reason we need implementation is because we're all good at changing policy, right? We're good at having papers or changing policy, but unless you actually implement, so carry that intervention into practice, and ideally with equity and justice and with quality, you won't have an impact. So this is what implementation is. And if we look at the kind of language around implementation science, we're always talking about real world contexts and user design and focus on the practicalities. But on the other hand, if we look at research, and I don't know what the balance of researchers and implementers is here, but research is about rigorous scientific inquiry, posing questions, reflecting. And often is determined by, particularly in the evidence-based movement, much more on kind of efficacy and control. So if we look at the difference here for implementation, we are often thinking about doers, and this is quite maybe stereotyped. And then for research, we're thinking about thinkers. And what we want for implementation research is to think about what we do. So that's the simplest definition that I would like to put out for implementation research. And then I'd really encourage you to look at this paper on which is led by the wonderful and really nicely put paper on implementation made too simple, which puts out these terms, which I've put into the circles: doing the thing, which is another way of thinking about implementing, and then research, which is studying the thing. So if we bring the combination of those together, doing the thing and studying the thing, that is a clear way for us to think about implementation research. So the study of how best to help people or places to do the thing. So sometimes in science we complexify things and add lots of fancy words. But I think this is the essence of what we want. How do we reach everybody with interventions that are done better, and how do we enable both people and places to enable that to happen? So if that's the definition, how do we go about it? Well, you know, all of us will be very familiar with the evidence-based movement, now many decades of this, about how to study the thing, how to compare one intervention versus another intervention, one antibiotic versus another. And if you look at this pyramid, the top of the pyramid is systematic reviews, and the inputs to those are usually driven particularly by randomized trials and also by cluster randomized trials, but by randomized design. The lowest part of the pyramid is what people say, and yet often in implementation and policymakers, a lot of the decisions are made by what people say. So if we move forward then to say, how does this work for implementation research? In fact, it's pretty scary. There are a really huge number of research frameworks. So at least 61, maybe more than that, depending on how you define them, for different extensions of them. There are 72 at least different implementation strategies. There are more than 400 different measures, and even in one of the most widely used outcome measures for implementation research, Proctor et al., there are 17, and you'll be familiar with a lot of these terms: accessibility, and of course, importantly, cost and fidelity. And then there's the consolidated implementation research framework, which is also quite widely used, but it's still quite overwhelming. So if we move forward to really boil down to what are we trying to do, the critical thing is the question, whether that's the king or the queen or the empress or whatever it is. So to be very clear on what our question is, to be very clear on what our implementation design is, and then for both to keep them as simple as possible. Don't feel like a randomized control trial is the only evaluation design for everything. So within this, looking at both your intervention approaches, and here if you have something that is still newer or not proven, of course you do need more rigorous research for that. If there's safety issues, even in rolling it out at large scale, or if it's going to be large cost, all of those things may drive you to a more rigorous design. But if it's a well-known question where you're really looking at how do I make this work in different contexts, how do I reflect on that, a mixed methods approach and looking at barriers and enablers, you know, may be what is needed, or at least what is needed to get you going to link to action and think of a bigger design if that's necessary. So I have the privilege of being part of the Nest 360 Alliance. This is 22 organisations working across 5 African countries with governments, and we'll be in about 150 facilities during the year 2025. And within that, of course, we're bringing in a package with HR and devices and so on, but it's really the data that are foundational to change. So there's many embedded implementation research questions, and they may be at small level, like some of these examples. So for example, I'm going to show you a few on closing the blood culture gap. They could also be at bigger level. So across 65 facilities, with a data set that currently has about 500,000 newborns in, we're looking at mortality change, and then linking that to inputs and outputs for health systems analysis and cost. And that does need a more rigorous design because it will have larger implications across many countries. But to give you a few examples of some of the implementation research in practice, so this is a paper that's published by Sarah Collins and about 40 different authors from across Africa. What you can see here is a data set with about 150,000 newborns, and here's the different countries. This is admissions, And what you can see in this bar is antibiotic use. And for example, in Nigeria, considerably more than 90% of all admissions to newborn wards are getting antibiotics. And then what you can see in this small bar is the percentage of babies who are getting a blood culture, and then lumbar puncture is even lower. And then you can hardly see the ones that are looking at antimicrobial sensitivity. But what you can't see in these averages is outliers. So this is an important principle when we come to think about implementation research, positive outliers. So for example, a facility that has a very high blood culture coverage. So then that leads us into qualitative questions. So across these facilities, all of whom would have the capacity to do something in a lab, there are some that are at 0, and there are some that are at 60%. So why? And I'm not going to go into the details here. This is work in progress, but some of the things are things that maybe you don't think of if you're coming from a different context. So for example, out-of-pocket payments for blood cultures for families, stock outs of blood culture bottles, lack of faith or communication between the lab and the ward, and so on. So these are really practical questions that implementation research can answer and lead to change on. I just want to show one other slide on some of the work in progress, because I know that many on this line are world leaders on AWARE. So we looked at AWARE criteria across these countries. And for example, I showed earlier that Nigeria is giving antibiotics to 96% of these neonatal admissions, and yet a large proportion of those are not meeting AWARE criteria, and some of the antibiotics being used are actually quite scary. So really important to look at this and see how that can change in context. I want to end with a few practical slides. First of all, are there places that you can get useful input? So here's a list of some helpful review articles, and I'm sure there are many experts on the line who could add to these. But I want to highlight again that the Jeff Curran piece on implementation research made too simple, which is really fantastic. The David Peters piece. Some websites, so the WHO TDR website has an amazing toolkit on implementation research, and also a MOOC. And then, for example, the RE-AIM site has very helpful frameworks and a wide use and examples, and I'm sure there are others that people could add. So how to get going? Well, if you want to get going, first of all, I would say pick an actionable and answerable question that matters and keep it clear. Then look for what people are doing already. So for example, you could go to the Newborn Toolkit map, you could look for other papers, you could ask around. Don't be scared to ask other people. And then importantly, you want to use a theory-based approach and be reflective, and then probably have an organizing framework, and ideally don't invent a new organizing framework. So for example, in NEST, we use an adapted version of the WHO and UNICEF 10 core components for neonatal care, which is mainly the WHO health system building blocks, and that's the basis for our toolkit. So I want to end with just showing two important places where we would love your community to join together with us. So on this newborn toolkit, which is deliberately brand neutral, similar to what you're trying to do in Revive and GARDP. We want to go faster together. So this is multi-country, multilingual learning. We now have 55,000 users over the last year, and regular webinars. And we did a joint webinar with your team in September, which was really fantastic. We would love to do more with you, and we welcome you to input, have ideas, suggest your tools, suggest webinars. And then I want to end with this Lancet Commission. So of course, there are many Lancet Commissions. Why do we need another one? This one is agnostic to topic and is about the principle of bringing evidence and implementation together. And in this commission, which is anticipated to come out in 2026, we really want to hear from you. So please do have your say, answer on this survey. Please share it widely and we welcome your inputs. And I will stop there with much appreciation to the team. Thank you so much.
Thank you. Thank you very much for this excellent overview of implementation science and implementation research. Our next speaker is Malabika Sarker, who is an implementation researcher and mixed method expert in the School of Public Health at Brown University in the USA. She has taught across 4 continents and has extensive research experience in Sub-Saharan Africa and Bangladesh. And before joining Brown University, she was the Associate Dean and Professor of the James P. Grant School of Public Health at the Brak University in Bangladesh, where she founded the Center of Excellence of Science of Implementation and Scale-Up. She has been awarded over 10 million in research grants and has published around 150 peer-reviewed articles and 5 book chapters. In 2018, Malabika was awarded the Heroines of Health Global Award. She's a physician with a master's in public health from Harvard and a doctorate degree in public health from University of Heidelberg in Germany. So in the next 15 minutes, Malabika is going to talk us about antibiotic dispensing and usage practices in resource-constrained settings, a potential driver of emerging antimicrobial resistance in Bangladeshi communities. Please, Malabika, the floor is yours.
Thank you very much. Thank you for inviting me. And this research was like a disclaimer that was mainly done by my student Abdullah Masood. That was his PhD research, and I was his supervisor. So I want to start with this picture in Bangladesh, which shows what's happening in the health system in Bangladesh. So 80% of Bangladeshi, their first contact point for any treatment or consultation is the pharmacy. And the pharmacists, those who work there, they are not pharmacists. Most of them may be high school graduate, or many of them even not a high school graduate. They work there, but they are referred as like a drug seller. So these, the drug seller or those who are working the pharmacy, they're jack of all trades. So they do the consultation, they sell the medicine, they give the injection, they go home. Sometimes they also offer the treatment. So these drug seller or pharmacist has a huge influence in the community, and there's a community trust that they go there as and access the care as a primary care giver or primary health provider. So let's look at the global scenario that it's like, we are aware about that almost 10 million annual death by 2050, or nearly 80% of the antibiotics are consumed in the community. There's an increased antibiotic consumption, almost 65% increase since 2000. And 2/3 of the antibiotic in South East Asian countries are consumed without any prescription. So it's an over-the-counter drug. Sorry, can I go back, Victor? Because it's, so the Bangladesh, it's a small country. It's 57,000 square mile with 170 population. Although we achieved a lot in terms of the maternal child health care, but the emerging threat is the antimicrobial resistance. And the reason is this: all those pharmacies, I already mentioned that they sell the medicine, but another aspect of this antimicrobial resistance is the aggressive marketing by pharmaceutical company. Those who go to this pharmacy and then promote the antibiotics to the population. So what are the gaps? So the major gaps is socio-political. There's a limited knowledge of antibiotic use. from the provider perspective, but also the community. And there's a resistance among customers and sellers because the population they don't want to pay the consultation fee, go to a physician. So they can go to this pharmacy and directly buys the antibiotic, and they don't have to buy the full courses. Sometimes they just buy 2 or 3 antibiotics until the symptom relieves. They take it and then they stop taking the medicine. So adherence is very low. There's a weak policy enforcement. We do have an civil policy, but the enforcement or implementation is very weak. If you look at the health system, there's very poor focus on this community-based antibiotic dispensing and consumption. So all these pharmacies are like uncontrolled or unregulated. There are some initiatives to introduce the model pharmacy and then rewarding them, but all over the country there are hundreds, thousands of those pharmacies every corner in the block. If you look at the research gap is mostly the research have been done in hospital setting rather than exploring what are the root causes of this antimicrobial resistance. So there is a standard treatment guidelines in Bangladesh for the antibiotic uses, and which is a wonderful document and very detailed, that published in 2021. But if you look at the literature, there's a growth of literature on the antibiotic resistance in Bangladesh, that how this antibiotic resistance is increasing, particularly among the patient from children to adult. So my student, Abdullah Masood, who is a PhD student from this, like the basic, from this context analysis, that we came up with the research question that he was very much interested to know that what types of antibiotics are procured from those pharmacies and what are the factors that influence this misuse of antibiotics. So this is like a multi-method study. It was a PhD project, so there's time constraint, also the funding constraint, but we tried to kind of triangulate using different method. So there is an antibiotic purchasing survey. This is the customers who come to the pharmacy and then buy the medicine. And then there is a follow-up survey with them after they left the pharmacy, because we collected their telephone number and there was a phone call, and we wanted to know about the adherence to the antibiotic they bought. There's also drug seller service, survey those drug sellers in the pharmacy, that 120 pharmacies in the 4 areas, the 2 urban and 2 rural areas, and the 2 urban were the Dhaka and Chittagong, which are the largest urban city in Bangladesh. There's also structured observation in the pharmacy to through the whole day that Abdullah sat in the pharmacy and then did the structured observation, that what type of antibiotics they buy, that the interaction with the drug seller or pharmacist. We also have conducted in-depth interview and key informant interview with different stakeholders. There's also simulated patient method, like, they're simulated, but that findings we are not going to present here. Professor John, Joy has already shared the award, this Access Watch and Reserve, where the Access group contains antibiotic used in the first and second line treatment, and the Watch group, the broad spectrum antibiotic with a high potential of developing resistant, and the Reserve group is the last resort antibiotic used for multi-drug resistant. So when you observe that what type of antibiotics the consumer purchase, we wanted to kind of categorize them into these 3 categories. So if you look at the antibiotic purchasing practice, you can see that like almost more than half, like 57%, they purchase without a prescription, and primarily for treating symptoms like headache or fever or cough. And we also found that interestingly, those who are children under 5 years and the elderly, they are more likely to bring the prescription. But those who are adult or the children more than 6 years old, mostly the medicine is bought for them without the prescription. And the higher prescription it's very much symptom based. So mostly it's the respiratory tract infection and enteric fever. And during the survey, the consumer, after they bought the medicine and they left the pharmacy, we did this telephone interview, and we found that the adherence is very poor. And but the patients who came with a prescription or consulted a physician, their adherence is much higher. Rural residents, like in outside Dhaka and Chittagong, there is a lower adherence. But mostly we found that respondent who kind of knew the antibiotic doses, that knowledge or information they have twice likelihood of adherence. And the dose does matter. The drug, if it is 12 hourly, is much easier to take, so adherence was higher, which is the predictable. And when you interview the drug sellers, their knowledge was very poor about the antibiotic use or antimicrobial resistance. And even they, or 58% didn't know that there's an antibiotic dispensing policy, that how much antibiotic you will give for what symptom. And antimicrobial resistance is it's really, there's a lack of knowledge, because 3/4 of those drug sellers, they recognize the link between antibiotic dispensing MR, but they didn't know that how it happens, the process. So they knew that, okay, if we take antibiotic, there will be resistance. But the problem was that the dose or the duration or adherence, they were not aware of that. So we did, during the interview, the patient, we did a simulated exercise with the drug seller. We said that these are the symptoms, what type of antibiotic you will provide, and you can see that mostly the upper respiratory tract infection, gastrointestinal infection, there's a universal prescription of the antibiotic, and which is belong to the, when you categorize them, they are the watch or access categories. Slides are slow. We also interviews with the multiple stakeholders, and this is a busy slide, but I just wanted to share that there is a structural issue, there's a conflict and rational choice, that the consumers, they felt that it's a short term because you have to pay less, you don't have to go to the physician, you can go to the pharmacy and buy the medicine. And there's also the perception of that the drug use, and all these lead to overutilization, irrational use, and sometimes underutilization also. They don't take the medicine on time, and it causes emerging antimicrobial resistance. So to way forward, it's very important to bring all the stakeholders together, and it have to be bottom up, that community awareness, the training of these the drug sellers. We found that those who receive the training, they have a much better knowledge, or much aware about the antimicrobial resistant and dispensing antibiotic than those who are not. There have to be execution of the policy, those standard guidelines. But this is also very important to not only focusing on the drug sellers, but also physicians too. The communication with the consumers, or communication with the patients or clients, to make them understand why it is important to adhere the medicine, to adhere to the antibiotic and complete the doses. So that we need a very effective antibiotic stewardship with relevant regulation, robust monitoring, and targeted awareness campaign, not only for the drug sellers and physicians, but also the consumer. So this is the study team, and Yeah, that's some reference. And the final slide is with my student and those who work with the qualitative researcher in the data collection. Thank you very much.
Thank you very much, Malabika, for this amazing work and presentation. Our next speaker is Christine Halleux, who is Unit Head for Research for Implementation at the Special Program for Training and Research in Tropical Diseases, TDR, where she coordinates a large portfolio of projects in implementation, research, including projects focusing on antimicrobial resistance. And prior to TDR, Christine worked several years in a medical humanitarian organization where she led medical programs and implementation research in several African and Latin American countries. She also worked in pharmaceutical industry focusing on knowledge management and research quality. Christine holds a medical degree as well as a doctorate degree in biomedical sciences from the Catholic University of Leuven in Belgium, and she has received postgraduate diploma in tropical medicine from the Institute of Tropical Medicine in Antwerp, Belgium. And Christine is going to talk us about challenges and opportunities in the conduct of implementation research for the use of antibiotics. So thank you very much, Christine, and please.
Thank you very much, Fernando, and very happy to be with you today, and thank you for the invitation and the opportunity to share a bit our experience in the use of implementation research on the field, in particular as a support for the appropriate use and the access to antibiotics. And really happy to be with the community today, with all the experts who knows and has a lot of experience on the field with that. I know that Joe gave you already a very good background on what is implementation research, but I just would like to give two examples to set the scene for the remaining of the presentation. And just taking those two examples, we know from the data that we have every year about more than 350 million of people who acquire sexually transmitted infection. But we also know that most of them would lack access to screening, diagnostics, and appropriate treatment. We also know from the data that only about two in five people with drug-resistant TB will access appropriate treatment. So you see immediately that there are really big gaps in terms of access to appropriate health technology that have been, however, proven to be very useful. And we know that those gaps exist, and we need to try to bring the gap and making sure that the different health interventions that have been proven useful come to the population. We know that over I would say the last decade, really major improvement have been done in terms of access to health. However, there are still a lot of implementation gap. And I would say that even if this occurs in all the settings, it's likely in low and middle income countries in particular for multiple reasons that we have seen those implementation gap being the most important. And those gaps are actually making that the impact that those health interventions that have been proven are really reducing really the quality of life. So Joy presented the definition, very multiple definition of implementation research. There are many, but I think what is important to remember is to understand that the implementation research can really help the country, can really help the different stakeholders to understand the relevant context and the barrier to the field, the barrier when we have challenges for implementation, those new health interventions. So the implementation research will help you to understand the context, but also will help you to find new approaches, new effective strategy to overcome those barriers. And the implementation research done on the field will help you to provide the evidence that will support the scale-up of intervention and driving, hopefully, policy change and practice change. You understand immediately that if we need to have contextual evidence for the implementation research in order to drive the national or the local policy change and practice, we really need to conduct that implementation research on the field. What you can gain as evidence in implementation in the North country may not be applicable in different settings, where the context is completely different in low and middle income country. Therefore, we really need to make sure that we bridge that implementation gap, that we have implementation research conducted by local team, answering local priority in real life settings. And this means that you need really to work from the field. This, in many of the contexts, considering working with Ministry of Health, with different local hospital or different partner active in provision on health services in low and middle country, has some of the challenges. First of all, the challenges of sometimes a limited research experience on the field. Some of the different health systems that are the bottleneck do not have experience in conduct extensive research in the past. So you need to bridge and to overcome those challenges. Very often we have limited resources also in those settings. There are also obviously competing priority. If you look at the multiple tasks that the different health workers have to do in hospital or in the primary healthcare settings in low and middle income country, there are really a lot of different things. So there is very little room, they would say, to conduct research. And also there is the complexity on bringing different stakeholders that needs to be involved in the prioritization on the research question, agree on what's the priority, but also agree on the strategy that may be useful and how to implement them. So you see directly that conducting implementation research on the field, it's not necessarily an easy piece of work. However, we should not be stopped by those challenges. And we really believe at TDR that embedding research into practice, in particular in low and middle income country, is actually an opportunity to bring a different culture of learning. Because when you start to take the habit to look at and try to understand what happened, try to understand what are the bottlenecks, it gives you then a different, an opportunity to act on those problems and in the long term improve the efficiency in health system. So working with the local team, helping them to understand how to conduct research and building that capacity for research, we really believe that we are building a long-term capacity and resilience within the health system. So we see implementation research as an opportunity to really make health system more efficient, but also more prepared to respond to any future challenges. Because once they have learned on how they can actually address bottlenecks, what to do to understand what's the problem and how to work to find new strategy to overcome those barriers, probably in the long term, they have much better equipped to resolve any upcoming challenges. So we see really implementation research as an opportunity in the long term. When we talk about implementation research on the field, there are usually two types of approach. There is the program evaluation or understanding what's the context, and Malabika has given us a very good example of what maybe implementation research with that focus. So she gave us an example really of understanding what's the practice around use of antibiotics. This part is really what we call the program evaluation or context understanding. But the other aspect of the implementation research is an approach that is about piloting or testing different implementation strategy. And that's where you're going to identify what may be your way to approach this problem and try to see if indeed those new strategies may help bring the result you are expecting. Okay? But whatever is the research focus, what is important really is to make sure that we engage a local partner. And I think Joy also insisted on that. It's important that the local partner or the local team take really the lead in conduct implementation research. Another important point is really the prioritization of the research question, making sure that there is an agreement. The research question is indeed a priority on the field, and the research question and the strategy that may be tested is actually something that can, and a strategy and approach that can be scaled up, and also that has the potential to bring impact. So those general concepts of course apply across a different range of topics, but they would apply also the implementation research can really be applied also as a tool to optimize use and also access to antibiotics. And if you remember, the WHO Global Action Plan for Antimicrobial Resistance actually is also highlighting and making room for research. The strategic objective 2 of the Global Action Plan on AMR is really about strengthening the knowledge and evidence-based through surveillance and research. So just really to reiterate the importance of implementation research as we want to move forward in tackling antimicrobial resistance or bringing better appropriate use or access to antibiotics. And so now I would like to briefly give you a bit of an example on a research package, how we have been, through implementation research, able to support the introduction of a new treatment regimen for a drug-resistant TB. So that's give you a bit of a more concrete example over those very generic concept that we have been approaching. And first, let's start to go a few years back. In 2019, the WHO released a new WHO guidelines on drug-resistant tuberculosis treatment. And in 2019, it was the first time that the WHO introduced in the guidelines recommendation a reference being made to shorter all-oral multi-drug resistance regimen for the use of drug-resistant tuberculosis. So that was a major change and really a major hope for both the patient and the health system also, because having first shorter regimen, but also regimen that include only all oral drugs was really a major change. Because for those of you who know a bit on TB, very often and in the past, the only treatment that was there was very long treatment, but also including at least injectable and other drugs. So it's a multiple of drugs. And this is quite difficult in terms of for the patient, but also for the health system. It's always much more complicated to have to administer treatment with injectable versus when you have all oral treatment. So this new shortened regimen that has been allowed because bedaquiline has been actually come up to the market were really a change for the community, the TB community. And it was really a hope for many of the TB program. However, because the recommendation was based on limited evidence, the WHO guidelines recommended that those shorter all-oral regimen be actually introduced or explored under implementation research condition. So if for many countries or in many patients that was really an improvement to have access to shorter and all-oral regimen, it was at the same time a real challenge for the country. Because you can imagine for a lot of those high burden TB country, of which a lot are, many are in low middle income country, not all those countries are really actually experienced in conducting research. So asking for the introduction of those regimens under the condition of implementation research was really a limitation in terms of access. But that was the recommendation of the WHO, given the limited evidence that existed. So TDR, the Special Program for Research and Training in Tropical Disease, along with the WHO Global TB Program, decided to develop a research package. A research package that would be a generic protocol to give, if you want, ID to the two countries on how they could implement that research or implement that new shortened all-oral regimen in the context of implementation research. And the research package had a double objective. The first one, of course, was to facilitate the conduct of the research in country for the use of all-oral shortened regimen. Because by the fact that if you give a protocol already ready, it's much easier for the country than having to develop their own protocol, trying to find out how they're going to develop that, in particular for those countries that do not have very large experience in research. There was a second objective also. It was really to provide a way to harmonize data collection in order to collect data that could be more easily analyzed all together and then provide more evidence to inform any future revision of the drug resistance TB guidelines. And so the research package was developed then really to help the country to move forward with the research at field level. So the package in itself constituted of a master protocol, a generic protocol that was released in English, French, Spanish, and Portuguese, just to make sure that then we would not have the Behavioural translation of the language for the country that may want to implement the research. The protocol was coming with the different documents that are required for the research. So, for example, data collection form, paper-based. There was also an electronic data capture form that was already built and could be adapted. And there was also different standard operating procedure for the study, as well as quality control tools. So all those were prepared as a package that would then allow really the different countries that were interested to jump into the research, if you want, more quickly or more easily. And this is very briefly an example of the different document, the quality control tool that were accompanying all of those, also developed in the different language. This slide shows you a bit then what has been the result, or what we have been able to achieve. As an example, this is for Cambodia. So one of the countries that had decided that they wanted to engage to start those shortened all oral regimen treatment. And so the country decided that they would like to implement the protocol. And so we had some conversation with them. And here's the timelines of the different main steps in the development, the planning of the research and the conduct of the research. And as you see, in November 2019, it was the first in-country visit to discuss the protocol adaptation, to look at the study site, to work with the stakeholder engagement, help them to adapt also the different data collection tools. So the generic protocol, obviously it's a generic protocol, but then it can be adapted depending on the context of the country with very minor adaptation. And so following that visit, there was different work conducted in the country, submission to the National Ethics Committee, approval from the ethical approval from the local ethics committee. And then within 3 to 5 months, the country was ready to launch the study and to start patient enrollment. So for those of you who have been working a bit in terms of research, actually looking at 3 to 5 months to be able, from the moment you start to preparing your protocol and initiating your study, is quite quick in terms of implementation. So really the fact that they had a generic protocol to work with at the beginning really allowed them to went really quickly into the planning and the implementation of the research. You have to remember also that the time was really falling at the beginning of the COVID-19, so really the 3 to 5 months were really quite a good result for the country. By October 2020, the country has completed the enrollment of the target sample size for the country, so we're really satisfied with the experience with the generic protocol. And this slide here gives you now an update, an overview of the situation right now, the global uptake of the short research package. And as you see, there are quite a large number of countries that have actually taken the protocol for implementation. We have 37 countries using the short research package, plus 13 countries in the Euro region that are using a modified research package. And the implementation of that research has been really supported also by a large number, very different stakeholders that are working with many countries in terms of implementation of TB program in different countries. And I think one element that has been quite important in terms of implementation, in terms of uptake of the research protocol, was also that the research protocol, when it was developed as a generic protocol, has been really developed, bringing together also those potential stakeholders, just making sure that there was an agreement how it was presented and prepared. So having really the different stakeholders contributing early on to the preparation of the protocol has been really one of the elements that has helped the uptake of the implementation research protocol. Okay, and I think with that, I think I will close, but I would like really to take the opportunity to really make the call for more implementation research, and really to bring implementation research and see implementation research as a tool to help us really bridge really that gap in implementation, in particular in low and middle income countries, giving leadership to local research community or to Ministry of Health and national control program to conduct the implementation research that will help them to reduce really implementation challenges. And that's in particular important in low and middle income countries, where we know that there is a lack of access to antibiotics, but at the same time also misuse and increasing antimicrobial resistance. So thank you for the opportunity, and over to you, Fernando. Thank you.
Thank you very much for this presentation, and thank you for the 3 presentations, because we're really amazing. So now we have some time for the questions and answers. Just maybe this slide to remind people how to submit their questions, that I will read to the speakers. If you have any your question is addressed to a particular speaker, please also indicate that in the question. We will try to, as much as we can, to address all the questions in the chat or in the question box during the duration of the webinar. So now I have one question here, so I probably start with this one. I also have some few questions from my own, but I prefer to give the opportunity to the attendants, of course, because so this question is quite broad. So, but I think probably it will be for you, Christine, because yeah. Or but any of you, if you want to answer, the question is if the aim of implementation research is to guide the intervention, or if the aim is to perform research to solve the intervention problem. So basically, I understand the question if it is to really understand how to introduce to do this intervention, or if it is really to solve the problem that prevents this intervention to be conducted or uptaken. So I think maybe Christine or whoever wants to answer, but let's start with Christine.
Thank you, and I can give a shot, and then anyone can complement. I think those 2 aspects are really interlinked in itself. The implementation research is not meant to demonstrate the efficacy per se of a treatment. This pertains to different clinical trials. But when you have a health technology that has been recognized as proven, it's really either to bring it to the field, help to understand what may be the different approach to bring something on the field, or find way of better implementing something. An example, for example, we know that there is a new formulation of pediatric praziquantel that will come to the field. We don't know how to roll it more, the best way to roll it in the different context. So implementation research can help you to test pilot those different approach and help you to then determine, depending on your context, what works better. And it might work better in one country in one way, or the other in the other way, depending on what you have as health system and all that. But at the same time, you can also use implementation research when you know that there are bottlenecks. And you use implementation to understand the context, but you can also use it to find a way of resolving those problems. So I think it's, in my view, it's really interlinked. But I think Joy and Malabika have large experience in implementation research on the field. So I would say I would welcome also their view on that.
Yeah, thank you, Christine. And yes, Fernando, I think important that we recognise that if it's an entirely new intervention, you need efficacy research. But the real strength of implementation research is to bring the implementer and the reflection on how to, especially a lot of the questions are how to. So, for example, some of the nice work that Malabika showed on the aware criteria and gaps. For example, in the NEST group, if we've got 96% of 500,000 babies getting antibiotics, and only 5% of them are getting a blood culture, then understanding why and how to change that, and co-designing with local contexts and people on what will work. And then I think often in implementation research we forget the money, but often the money is the single biggest driver. So also finding ways to make sure we count the cost, because that will be really critical in taking it forward. So I hope that helps. I think that I really love that implementation research made two simple questions. So the study of how best to help people or places do something that you already know. And that's utterly critical. The kind of no-do gap is the simple way WHO used to talk about it.
So there is another very interesting question. There are several questions, so I will follow some order, but and try to address everything. The question from the audience is if there are examples, or if any of you anticipate the use of technology like telehealth or artificial intelligence to accelerate implementation research activities. I don't know who wants to answer this question, or if any of you have experience on that.
Don't know if anybody else wants to comment. I can maybe say there are two different angles. So one angle is AI to help you do the research, and the other is AI within your implementation. So for example, within NEST 360, we're looking at how to have AI plugins to our neonatal data set, where we can look for signals of hospital-acquired infections in the absence of blood culture. So for example, 92 deaths in a hospital within a week and a half, and people not doing blood cultures. You shouldn't just ignore that. There should be a flashing light that AI can help you with, to then say somebody needs to go out and look for an infection, because that's the most likely thing. And it turns out to be Klebsiella in the gentamicin bottle. So you need to go and pay attention. I don't know if others have suggestions. There is quite a lot written on using AI to help you refine your search criteria to get promising interventions and so on. So you can also use it the other way around. Over to others.
So one of the I think very important AI use now in the Philippines and Bangladesh, that using artificial intelligence to diagnose diabetes retinopathy. So you can have the primary healthcare worker who will take the retinal picture and the handheld camera and then diagnose that who are suffering from diabetic retinopathy and refer them. But it's interesting that everybody's talking about that and it has been implemented, but nobody's doing the implementation research, that execution of the process, because we are so much obsessed with about the health outcome, the cure, or but not the process. So that could be interesting, but so far I know that there's no implementation research looking at how those primary healthcare is executing that, and what is the referral structure, what percentage of them are really going to the health facility, or whether the patients are accepting that they are not going to the ophthalmologist. But so this type of AI enabled the better diagnosis, the better referral process, there is an opportunity for conducting a lot of implemented research. Otherwise, it will not be successful, or execution will not be optimized. Yeah, over.
Yes, thank you very much. Yeah, I agree. It's a field to explore and difficult sometimes. But now there's one question which is interesting for us, for GARDP in particular, because it's more focused on AMR. The question says that given there is a huge range of potential implementation science questions in AMR, how would you recommend the AMR community prioritize potential implementation research questions? We heard, for instance, from Joy, the toolkit for neonatal, but I don't know to my knowledge, there's nothing like that to identify the gaps in AMR. So I don't know if you have any thought on that prioritization, and I address the question to the three of you because I think it's important. So please.
I can give it a very quick try, and then you can complement. I think there are priority on AMR. There have been priority that have been set by the WHO on they went through a specific research prioritization exercise, but that was broader. So that's not only on implementation research, but if there were a community would like to do prioritize implementation research, I think can be done through the same process. There are guidance on how to do the appropriate research prioritization exercise, and I think it's an important one because I think it's important that not everyone goes with a research question, which is actually not very important. So the community, in particular the international community, should kind of come together and make a discussion on the prioritization exercise. So I know it exists at the AMR level, but I'm not sure that it was done for the implementation research specifically. But Joy, you may have been involved in that process, so you may know better.
Yeah. I mean, first of all, Christine, thank you, because we all need a strong WHO at the moment, and WHO's job, as well as norms and standards and data, is also to guide on research priorities and to try and make sure they're based on evidence. I think it's in the motto, isn't it? Science-based policy. So, I think there's always a risk that we, it's kind of the loudest voice or what somebody, says. So I think really some of the research prioritization exercises that we have seen, really need to also look at local voices and what matters, and then also what's likely to lead to impact. And then if they're global priorities, they should cut across more than one context. So, for example, there are systematic research priority setting scoring methods, such as the Child Health and Nutrition Research Initiative. And I think Sashio, I'm just forgetting her name, she used to work with Rajiv Bal in WHO, but she did her PhD with us at the London School looking at that method, and so, on possible impact, feasibility, equity, and so on. So you score lots of different questions as rows, and then you have the columns and you add up the questions. And if you can get several hundred people to score that from lots of places, that's better than 5 people sitting in a room and telling you what the priority is, because often that's the loudest voice from the Northern Hemisphere. So we should try to get beyond that. So maybe WHO, you could take this on. I mean, you're leading on implementation research and leading on AMR. It would be great.
But
Go ahead.
No, but I said that the prioritization needs to be linked with the problem and the context. I don't think that any, there could be global guideline. But for example, in Bangladesh, the major problem is driving this, the drug seller who are selling the medicine. And there could be a very interesting or important study, the co-designing that how to train them and what do they need, and then conducting a research to look at the effectiveness of their training in terms. So it's like when we prioritize and implementation research, that I think before that we need to identify, diagnose what is the problem in the implementation process, and then prioritize based on the magnitude of the problem or the importance of that problem. And then methodology comes later, which is much easier. But it needs to be very contextual and the problem focused.
And if I can just add, Fernando, because I think it's an important, both Joy and Malabika have highlighted that the fact that there are things that we can have a global agenda for some question, but many of the implementation question, you do not expect to have a prioritization that's global for. It's really going down to the country, to the local context. And that's really the important to understand, is that you cannot get the evidence you need for implementation from one country that necessarily is going to be copy-paste to the next one. So there are possibility to have some prioritization, but we have to be very careful that it needs to come, as Malabika said, and Joy, comes from the field. So yeah.
Yes, yes, and I agree, and that is probably one of the difficulties of you mentioned, Joy, the problem of funding, and probably some of the donors they want broader, larger cross-country impact, and here by definition we're talking about something that resolves problems for a community or for a country specifically. So yeah, I understand the difficulty. I have one precisely on a specific country. So for you, Malabika, thank you for the excellent presentation. And the question says that there is the pharmacists are critical to stop the misuse and abuse of antibiotic in the community. And in Bangladesh, you mentioned there are no pharmacies. So from your experience, what are the correct approaches to tackle this problem in LMICs? Because it is not only in Bangladesh that there are no pharmacists dispensing drugs.
I think there need to be short-term, mid-term, and the long-term strategy, because within a week you cannot replace all these drug sellers to be pharmacies. So first we need to start with the training of the pharmacy, and it have to be co-designed with them. We should not go there and say that, oh, take this training, that to understand what's the reality, but parallelly that awareness of the population. And there could be some legal that certain antibiotics should not be sold without a prescription. That can be enforced. Of course, there's some broad spectrum antibiotic. Then the midterm, I would be say there is a stigma. My sister is a pharmacist, but they don't want to work in pharmacy. In Bangladesh, they feel that it's a lower position. That is not that if I study in university or college, why would become a seller, drug seller? So that stigma, I don't know how can it be done with the advocacy or awareness or certain incentive, and then slowly within maybe 5 years or 10 years or maybe 10 years that replace those pharmacists by a trained pharmacist. And it can be done. You don't need a university graduate pharmacist, but at least 6 months or 1 year training. So that have to be a very stepwise process. But with it, like in Bangladesh, I'm a physician. The physicians even don't acknowledge the informal provider or those drug sellers, that they exist. First, we have to accept that 80% of the population go to them. It might be bitter truth, but most of us physician or the doctors community, they don't want to accept that fact. And after accepting that, then we can proceed with certain steps. Yeah, but there have to be short-term, mid-term, and the long-term, maybe within 10 years or 15 years strategy. Yeah, over.
Thank you. And maybe just to continue, I have a question. In your specific research, you mentioned that one of the interventions you identified was, I think you call it, I have written somewhere, the need for contextually relevant regulations, and I love that. So my question is, did you achieve or did you manage to influence policy and regulations in Bangladesh, or maybe just the next step? But because I think the connection, which is important, is all these results are really changing policies or not. So I don't know if you have an opinion on that, or you can give us a little
Yeah,
bit
there
of
are a lot of discussion. You know, the one health approach is very strong in each country. But if I look at the one health approach, even for the post, you don't bring the veterinarian. It's dominated by clinicians and epidemiologists. So although one health is not one health, it's like a human health. But I would say that in Bangladesh, there are a lot of awareness. There are a series of research that, like, you know, that my colleagues are conducting, and the Ministry of Health and relevant the policymakers, they know they started those initiative, the training, the health worker, or the model pharmacy that acknowledging them, those who are. So, but that needs to be bring in one platform, and strongly suggested, not I'm like, you know, the implemented researcher, but there should be more implementation research, because we have this tendency to develop a product and implement it, execute it. That's it. We don't pay attention to the execution or implementation. Like the standard guideline, we have the antibiotic use. There's no research have been done whether even the physicians are aware about those guidelines, because physicians are so much influenced by the aggressive marketing of the pharmaceutical company. So the government also need to engage the pharmaceutical company, that those medical representatives go and promote the antibiotics. So there are a lot of initiative, but I think with the many countries, it's very sporadic. For AMR, we need to bring them together, and that's very, very important to bring all stakeholders and have a very comprehensive strategy and talk to each other. Yeah. But I think it's getting better in Bangladesh, given this 170 million population, and antimicrobial resistant isn't like, threat.
Yes, thank you very much. And that was a little bit just a follow-up question, because I think this connection with the policy is something that is quite concerning. And I was wondering, it was mentioned by Joy and also by Christine, the use of some harmonization, the research toolkits, and the standardized protocols and data collection tools. So I was wondering, I would like to know your opinion if that can help, not because we saw you presented that the objectives are to facilitate research and to harmonize the data, but I was wondering if that can help also to have a bigger impact or an easier translation into policies when discussing with policymakers. So I don't know what you think about it, if there can be a third advantage of adopting these methods.
Yeah, I think indeed from our experience, yeah, the more evidence you have, the most you can hope to convince someone. However, I think that you still need local evidence. In some country, they really look at what has been the evidence, what is really applicable to the country. So as long as it's an evidence that can be transferable to another country, I think it's useful. But we have to be careful on how much this can be transferred. But indeed, having similar protocol help, of course, the conduct of the research, ensure that we have the data actually, the way when we say we harmonize the data collection is because that's helped, for example, WHO guidelines, because they need to have more evidence. But that can be also used when, having a brief, a policy brief for a country, because indeed they can see that amount of evidence being also useful to them. So indeed that can be also used, but depending on the context, you may or not be able to use it in across different countries, I think, for policy change.
I just want to add one thing, that as much as we talk about the toolkits and the protocol and then guideline, I have seen that in Bangladesh, the protocol is in the laptop of the district medical officer. So or it's very nicely the cupboard locked. So we can, so then again, these type of thing, we need very nuanced the implementation research, that all this protocol or guideline or toolkit, how much they're about, how much their adherence to those protocol, whether they have the initiative to train the colleagues about this protocol, even the fund for the refresher training. So this is also part of the implementation research, and we need to do that. Only having a protocol or tool or guideline, I think it's like in 10% of the work. You can bring now through webinar 50 expert or 500 expert and create a toolkit within 3-4 days. But executing and implementing and adherence to that is a whole new ball of game. And there we need a lot of practical implementation research about the process. Yeah.
And maybe to underline that too, I think policy can be cheap. So, we have trials, we get guidelines, people change policy, people have protocols. And I think what we're really talking about here is on the ground closing the gap on implementation. So the gap might be a consistent question, like how do you implement or wear guidelines? That applies everywhere in the world. That's the question, but the answer may be completely different. So how do you close the blood culture gap in Nigeria? The big problem is families have to pay $30 for a blood culture. That's not the same problem in Malawi. So, you know, what I see in the great learning for implementation research is there are often common questions that would drive impacts. We already often have the policy. It's much more how do we make it work and how do we sustain it in a local context that's really driven by local people's needs and wants.
Yeah, no, I completely understand. I was more thinking about precisely these changes at country level. So, for instance, to support families to pay the blood cultures or things like that. So, specific measures that has been taken after some implementation research. But I have maybe, I don't know how much time we have. Probably one more question, and then I will have to give the floor to Victor. So this question is more about something more concrete, and if I understand what they're asking is if implementation research can be useful for interventions that are not included in control programs, in vertical control programs. So if it can modify one of vertical control programs, and it gives the example of schistosomiasis, where there's already a lot of interventions that have been designed over the years, because it's usually are old programs, but if there's room for improvement through implementation research for these kind of vertical programs, if I understand the question correctly.
Should I try? So
Sure, yeah, sorry,
the
didn't say
question
who.
about using implementation research for strategy outside of the control program?
A
Yes.
vertical program, yeah.
Because I think implementation research can work with the Ministry of Health, with the National Control Program, but you can also target implementation research for any other aspect of the community, of the One Health framework. So this can be applicable in health, can be applicable in any of the other contexts. So I would say yes, of course, you can work, and you should think about implementation research to improve whatever other aspects. So definitively, I think, in my view, yes. But, yeah.
And also the best way to formulate implementation research question is working with the implementers. It should not be researcher initiated. It should be the co-initiated with the researcher and the implementers. It's not epidemiological study or randomized control trial of a drug that as a researcher, I formulate the question, I go. It have to be the partnership with the implementers and the researcher and the policymakers if we really want to have a very effective and relevant and pragmatic research question which is related to the implementation research. Yeah.
Exactly. I mean, there's always room for improvement. So I think we have 2 minutes left, and I will give the floor to Victor, who will close. For me, just to thank you very much for the presentations and the wonderful discussion.
Thank you so much, Fernando. Thank you.
Victor,
And thank you for your chairing too.
Thank you.
Great. Thank you very much, Fernando, for moderating today. And of course, thank you, Joy, Malabika, and Christine for your insightful presentations. So you can already register for the next Revive webinars that will be the first to take place in 2025. On 23rd January, you'll be able to attend a webinar on the importance of chemical synthesis for antimicrobial R&D. And also on the 27th February, you'll be able to attend another webinar on predicting human pharmacokinetics and dose of antimicrobials. So you can also subscribe to our newsletter through the Revive website, and also keep up to date of our latest on the X channels and also on LinkedIn. So that'll be all from us for today. Thank you for joining and contributing to today's discussion. I hope you found the webinar interesting and useful, and that you'll join us again in future. Please also encourage your colleagues to join as well. And please do fill in the survey afterwards to keep us informed on how to improve the Revive webinars in 2025. Thanks again and goodbye.
Thank you very much.
Thank you. Thank you.
Thank you, Victor. Super organised.